Hello, my name is Dre Yoav Keynan. Thank you for the introduction and the kind invitation. I want to start by acknowledging that I'm working at the National Collaborating Center for Infectious Diseases at the University of Manitoba. And our center is located on the lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. What I'll try to do in the next 15 minutes is review a big topic with a lot of evolving information that keeps updating rapidly. So what I'm going to say today will probably be wrong in a week or two, but I will try to say what is happening on the fronts of diagnostics and treatment of COVID-19. The situation as of yesterday, April 27th, over 3 million individuals were diagnosed with infection of the novel coronavirus, an infection that was first seen at the end of 2019 and then disseminated globally, leading to over 200,000 deaths. The numbers of cases and the burden of disease has largely been linked to connection of travel and importation of infection and then establishment of infection in widespread community transmission across European, North American countries, with resulting morbidity and mortality, and obviously significant economic burden and effects on global interaction and global communications. In terms of the numbers are largely affected by how we test, how the testing capacity, and do not necessarily represent the widespread dissemination of the virus, as some countries are struggling with diagnostic testing, and it also is affected by the public health action that has been taken by countries, from complete closure to countries that had more lax interventions in place. What we know about the virus is that as opposed to the coronaviruses that are seasonal, this one is associated with significant morbidity and mortality. And in contrast to the coronaviruses that were the SARS in 2003 and the MERS-CoV that was the Middle East coronavirus several years ago, this virus is more adapted to transmission among humans. And this study that you have in front of you in the slide from South Korea shows that a large proportion of the cases stemmed from two infected individuals with large dissemination cycles, showing the potential of this disease to be transmitted in the community and propagated. The problem with this virus is the fact that it differentially affects more severely the older population and people with comorbidities. And if we don't take public health interventions, the risk is overwhelming of the medical system, overwhelming of the capacity for intensive care units and mechanical ventilation. And without ventilation, the people that are severely affected by the virus cannot be receiving enough oxygen or oxygenated properly, and mortality then increases dramatically, as was seen in Italy when the system was overwhelmed by the burden of disease that occurred in a limited period of time. What are the ways to intervene? What are the public health interventions? So home isolation of cases, home quarantine of household member, most importantly, social distancing. And social distancing can be done to fractions of the segments of the population or to the entire population. But social distancing has been modeled in many models and shown to be the most effective way of decreasing transmission. And that has been the situation in Canada and to some degree it has been successful in making the peak of illness lower. And this mathematical model shows what would happen if we do nothing. That is represented in the black line. So you see the burden of disease is expected to peak early and to reach a higher case number, a higher demand on critical care capacity. If we then progressively impose interventions on public health, such as school closures and universities, you see that depicted in the green line. The brown line shows when you add to that case isolation, and then, as I mentioned, closing and social distancing is effective at decreasing the numbers. And the idea behind that is to allow for an increase in surge of critical care capacity and not to overwhelm it. but the effect of it is stretching of the epidemic with peaks that are not as high, but a curve that fades away more slowly. And again, based on those models, and this is a model based on Imperial College model, and you can access it online. They have great resources if you're interested in playing with the mathematical ideas. Basically, that shows that prevention of the first peak can result or can contribute to the fact that the transmission is longer, and there's a smaller percentage of population that has encountered the virus, and the prediction is that there will be secondary peaks. Hopefully those peaks will be answered or met by increased capacity and will not overwhelm the healthcare system. This is a mathematical model from a group that the NCCIH has been working with that was published recently in the Canadian Journal. This model shows that there are susceptible individuals that can become exposed, and those individuals that are exposed, if not isolated, can transmit the disease to others. Some of the individuals can suffer from severe illness, and again, you can either isolate those with illness or not isolate them. And of those with severe illness, a subset becomes overwhelmingly ill, and they require hospitalization, first in a setting of a hospital, but if more severe, they need to be assisted respiratory-wise and may require intensive care unit admission. And the percentages of each of those populations depends on the age and prevalence of comorbidities in the population. So younger populations with less comorbidities will have lower burden of intensive care admission, for example, and populations that are older and have more diabetes, more hypertension, more respiratory diseases, higher prevalence of smoking are expected to suffer a higher burden of severe disease and ICU requirement. And in this model, the group led by Dr. Mogadas from York University have imposed several scenarios from social isolation of 0%, so basically not taking any intervention, and in that depicted in the orange bars, you see that the ICU beds required per 10,000 would overwhelm the capacity that we currently have in Canada across the board in all provinces, and that is depicted in the orange bars. If 20% are self-isolating, then that would decrease the number of ICU beds to around 450 per 10,000 population. And if the social isolation will be more effective at 40%, this will be less than a half in 250. That is depicted in the red bars. So the point that this is trying to make is that the ICU capacity in Canada is decent, but will not be enough to cope if we don't impose social distancing and public health interventions, which Canada has successfully imposed, and some provinces did better than the others, but overall clearly different from our neighbor to the south. And this is another piece of modeling that basically shows that the infectious number is, so each case of COVID-19 is transmitted to an average of between 2.2 to 2.5 other individuals. And with public health intervention, we can decrease the burden of disease. Okay, if we decrease it to 2, then we can preserve our ICU capacity. So that shows that you can play with the models and show that if you decrease the transmission dynamics only from 2.5 to 2, there is a significant benefit in not overwhelming the healthcare system. The next steps of modeling is trying to look at what would be the optimal exit strategy, and you can exit this social isolation and the closure gradually, and you can break it down by age groups or by comorbidities or by different settings in order to protect the more vulnerable elderly population. So, for example, you can allow schools to come back and then allow working force from the age of 20 to 50 to come back, and preserving and protecting the ones above 50 and above 65 until later stages. So modeling is trying now to create or to review all of those scenarios to try to help decision makers find what model would work the best. In terms of diagnosis, that has been a topic for a lot of discussion. Next slide, please. Diagnostic capacity has increased dramatically in Canada, and all provincial labs have efficient testing. However, testing is reliant on reagents that are in very limited supply globally. So there has been a tremendous excitement about development of rapid diagnostics that don't rely on the same pipeline for reagents. A couple of the ideas include the Gene Expert, that is a platform that is used for other infectious diseases that has been adapted to COVID-19 and is able to identify cases based on PCR from a nasopharyngeal swab. Canadian company Spartan Cube is under validation for a proprietary kit that we're trying in several sites across the country. The next topic for diagnostics is serology. It's basically taking blood and trying to identify antibodies that tell us who has been exposed to the virus. There's several hundreds of products now in the market. Of them, 4 are FDA approved only. We don't know which ones work the best, and we don't know how to give someone a certificate of protection from the virus. But there is tremendous development in rapid diagnostics, in adaptation of ELISA or enzyme-linked immunosorbent assays and neutralization assays. And time will tell if we can use those to identify which healthcare worker, for example, were exposed, or if a person in a nursing home that works as a staff in a long-term care facility can be tested to identify previous exposure. The clinical presentation of the disease is from asymptomatic, and we don't know what percentage of the population that is infected is asymptomatic, but it runs between 7 to over 30% that are asymptomatic. Some individuals develop a mild respiratory disease, and that is the majority, over a half, and only around 10%, and that is age-dependent, develop symptoms. And symptoms can be divided to mild or severe disease, and severe disease can lead to hospitalization. Of that, of the entire population, about 4% required ICU admission and mechanical ventilation, and that group has a high mortality rate. The incubation period of the disease is a median of 5.2 days, but it ranges from around 4 to up to 2 weeks. Severe disease is manifested as high-grade fever and decrease in oxygen saturation that requires oxygenation, administration of oxygen or mechanical ventilation. And more recently, we're seeing disturbances in blood coagulation and strokes and other manifestations in patients infected with COVID. The death rate and the complications are dependent on the existence of comorbidities such as cardiovascular disease, diabetes, respiratory disease, hypertension, or cancers. And all of those make the likelihood of requiring intensive care admission and death much higher. There are many interventions that are being studied. There are no proven treatment at this time for COVID-19. There are things that we know that are not recommended. High volumes of fluids are not recommended. They may worsen the respiratory status. Giving steroids is not shown to be helpful and potentially harmful. Medications against hypertension, there were theories that those are contributing to the disease. There's no evidence that stopping them makes a difference, and the recommendation is not to stop them. The complications of stopping antihypertensive medications are severe. And if you listen to news from the South, don't ingest anything. Don't ingest or inject anything that is not supposed to be injected, such as anti-infectants. Those are not safe and should not be interventions. The virus itself enters the body. It's an RNA virus, and it enters through 2 receptors, including the ACE receptor, and then undergoes translation of the genomic material and uses protease to generate its own proteins and to assemble to a new virus. All of those in the picture have been potentially sought as targets for antiviral therapy. As I mentioned, there are no proven therapies, but unprecedented efforts to identify what would work for the virus has been undertaken, and there are now, as of yesterday, 587 registered clinical trials that explore all of those potential antiviral, changing the immune response of the host, modulating the immune response, and targeting host factors. Chloroquine and hydroxychloroquine has been promoted, but the evidence behind it is theoretical. They're supposed to affect viral replication and may also interfere with the way that the virus enters the cells, but clinical trials are ongoing, and so far the evidence is not showing any promise to me. Antiretroviral medications used for HIV have been tried in COVID-19 disease. Lopinavir/ritonavir is a long-used antiretroviral medication. So far, a study that was published in the New England did not show effect. That study is methodologically flawed, but further bigger studies are ongoing that will give an answer whether this could be a treatment. Remdesivir is the drug that was developed for use in Ebola. Didn't work for Ebola, but then was tried in the other coronaviruses, MERS-CoV and SARS, at least in cell models, and it looks like it is able to develop, to be incorporated into the synthesized RNA and inhibit viral replication, and it's now being studied in trials for COVID-19. First observational study showed some promise, and that study basically showed a decrease in ICU admission and mortality, but it's a small study that was not controlled, so we again will have to anxiously await the results of large clinical trials. The other medications that receive attractive endorsement, at least, is the tocilizumab or immunomodulators. Those drugs affect the interleukin-6, which is an inflammatory mediator that is increased in the presence of COVID infection and is thought to be responsible for some of the damage to the lungs and other organs. So attacking that immune mediator is a promising line of research, and there are several clinical trials that rely on either tocilizumab or other medications that block the interaction of interleukins. The last thing that I will mention in therapeutic options is taking serum, convalescent serum, from people who have recovered from COVID-19 and trying to isolate antibodies and to generate those in order to protect individuals that are infected with COVID-19. Again, clinical trials across the globe are currently enrolling patients, and we're planning to do so in Manitoba and in Canada. All of the studies that I mentioned before, there are studies in Canada, and trying all of those interventions as part of large multi-center studies. And it's unprecedented how the academic community has come together, and I've seen more sharing than I've seen in any other era, sharing of information and resources to try to get those trials up and running. There is a huge difference between different provinces. Some of them have restricted the use of medication just to the setting of clinical trials, and others have allowed more compassionate use to at the discretion of clinicians. Each approach has advantages and disadvantages and raises many ethical dilemmas of how we use the resources, but that's not the topic of our conversation today. So if to summarize, this is a rapidly moving field, and we are working on development of diagnostic modalities that are more self-sufficient and allow for quicker results and more capacity for testing, and to adopt as many flexible platforms as possible. No proven serological test at the moment and no correlate of protection, but studies are ongoing to try to identify what makes an individual protected and if we can measure that protection. And the last thing, there's no current proven therapy. Many of the proposed studies will not be successful, and it's important that we study formally and not use off-the-cuff interventions that may be harmful. And there's been unprecedented effort, rolling and rapid deployment of clinical trials so they can be accessible across the globe. And with that, I would like to conclude. Thank you very much for listening.